again. Now I think it's working, yes. Welcome again. Now I will discuss very shortly another novel endoscopic technique is cutting edge in the endoscopic field, which is endosonographic guided endoscopic gastroenterostomy. Also a new comer and big player in the field of endoscopy. And I think somehow it can complement the great and elegant technique that Dr. Khalid has just shown us. This is in many patients, especially with pancreatic cancer head, they have gastric outlet obstruction because most of the tumors can infiltrate in the duodenum, in the bulb, or in the second part, and they will have also gastric outlet obstruction. So we see many patients coming with cholestasis plus gastric outlet obstructions. So that techniques may complement each other. So I will start now talking about the management of gastric outlet obstruction. I will not discuss the etiology. There are different etiologies for gastric outlet obstructions. It's beyond our scope now. So the management, we have a patient with outlet obstruction. The standard is surgical bypass in many cases, laparotomy or laparoscopic, or you can put an endoscopic stent, covered versus uncovered. Also, it is another discussion. We can do double stenting, biliary stent first, and then duodenal stent. There are other methods for management of gastric outlet obstruction, like balloon dilatation, like gastric juice extractions by inserting a peg or with nasogastric tube. And what we'll discuss today is the endoscopic bypass. Endoscopically, they developed many methods for gastric enterostomy. Most of them failed, to be honest. The only one which is very promising and applicable now is the endosonographic guided gastroenterostomy. With a short and quick look at the literature, so they compared surgical gastric enterostomy versus stenting, versus endoscopic stent. The surgery was superior regarding the gastric outlet score, the patient comfort, how the patient tolerate his obstruction, and the recurrence rate was much lesser with in surgery group. The benefit or the advantage with the stent was shorter hospital stay, and they take solid food for or they can start taking food quicker than surgery. Now surgery versus EUS guided. Hashab group published this retrospective study. It is a nice comparison with 93 cases. Surgery was superior regarding technical success rate. Hospital stay was, of course, shorter with gastroenterostomy. Recurrence rate didn't show significance. Complications rate didn't show any significance. Here, we have to say that the advantage here in this endosonographic gastroenterostomy group that they can start eating at the same day. We start with clear fluid intake at the same day after the gastroenterostomy, and the second day they can start taking soft food. Now we will compare the gastroenterostomy versus stenting, the endoscopic. Both of them are endoscopic. Technical success is no significant difference. Clinical success, there is no significant difference, but the need for intervention was, of course, higher with the duodenal stent. If you will put an uncovered stent, the tissue overgrowth might close it. If you will put covered stent, the possibility of migration is also still very high. Complications didn't show any difference. So the techniques, how we do it. Again, I will talk about the hot axial stent because here it is a mandatory. So in the other two techniques, in biliary drainage or in the cystic drainage, you can put plastic stents, but here or other stents. But here, hot axius is the main idea or the main core of this technique. This I already showed in the last presentation, so I will cut it to the techniques. There is direct puncture technique, which I don't prefer. Sometimes you can't pass to the jejunum or deep in the small bowel. So some authors they they puncture through the stomach in collapsed small bowel, and then they filled with water, and then they do the gastroenterostomy. I wouldn't prefer this method because it is very blind method and very dangerous method. You can put a balloon deep in the small bowel, inflate it with water, and then use it to target with axial stent. You will make it like cyst drainage. Small bowel inflation with water. This is the technique I personally use, and it is preferred by many people who are doing this technique. And I will come to this in the next slide. And this device, which invented by in Japan, called EPAS, it is 2 balloons here, as we can see, 2 balloons. You will insert them in the small bowel, you will inflate them, and then to fix them, and then you will inflate between them with water. And the idea of the 2 balloons, they will prevent your inflation to skip downwards or upwards. And there is 2 endoscope techniques that you will come with the endosonography from the stomach and with the other scope from the small bowel, and then you will puncture under vision. I did it once, and to be honest, it is time consuming, and I didn't see any superiority for it. The technique, it is, first of all, you have to come in the stomach with normal endoscope, gastroscope. You will try to pass the stricture. If you can pass it, it would be enough to pass a wire, and over the wire you can pass a cannula. Then you will inject water to make sure that you are in good position. You will go out with your endoscope, you will withdraw endoscope, and then you will come inside with endosonography. And then you will start through this cannula, or this nasobiliary cannula. You will start to fill the small bowel with water, mix the water with blue, and mix it with contrast metal. The contrast medium, we can control it under fluoroscopy. The blue dye, we will use it later when we finish our procedure to make sure that we put the axis in the right position. When we see blue water coming to us, that means we are in the right position. So this is here the endosonography. This is the device, and this is the nasobiliary cannula, which is in the small bowel. As we can see here, we filled the small bowel with water mixed with contrast metal and blue dye. You will identify the loop, and you will puncture the loop with a needle. You will aspirate. If you will find what you aspirate is blue, that means it is correct. It is not colon. This is one of the biggest problem, that you puncture in the colon. So to make sure it is not the colon, you have to aspirate the blue dye. This is the video of the puncture. After you puncture it with the needle is just to make sure. I have to stop the video. Sorry. After you puncture it with the needle, you make sure you withdraw the needle out. You don't need the needle. It was just to confirm. Then you will come with the axial stent, and you will directly puncture with the axis, as we can see here again. So we have already punctured in the small bowel from the stomach with the axis. This is the distal part of the stent. We will open it in the small bowel. This is a very critical moment. You shouldn't deploy the stent unless you are very sure that you are inside the small bowel. There are some tips and tricks for this, but this is, I think, one of the commonest problems, that you deploy the stent in the peritoneum and not in the small bowel. And under endoscopic vision, you deploy the proximal part in the stomach. It is open now. You can do balloon dilatation. I did it at the beginning. I stopped to do it because I didn't have problem with the balloon dilatation, but I read many, and I have heard of many problems that happened with balloon dilatation, that the stent was dislocated. That's why just leave the stent in maximum in a couple of days, 1 or 2 days, it will be completely dilated to the maximum diameter. Once it is dilated, you can, of course, come inside the small bowel. Also, I don't recommend it anymore because it is dangerous. The stent can dislocate. Usually, to have a fixed track, you need something between 3 to 4 weeks. Of course, you can't remove the stent before that. Complications that can happen during this examination, of course, peritonitis, if you have leakage, if you punctured with the axius and then you withdraw it back and you made a perforation in the small bowel, of course, you can have peritonitis. Bleeding is very rare. I didn't see it. It is has very low incidence. Misdeployment of the stent is the commonest thing, and it can be very dangerous. You can misdeploy the distal part in the peritoneum. You can perforate two walls of the small bowel and then misdeploy it in the colon. Perforation can happen. Gastrocolostomy. But as we have seen, at the end, the incidence of complications generally is not that high. This is another example. When can you use endosonographic guided gastroenterostomy? So I talked about gastric outlet obstruction. Another entity is afferent loop syndrome. And what is this? It is a syndrome caused by mechanical obstruction to the afferent jejunal loop. As you see here, this is the afferent loop. We have here a mechanical obstruction. So we will have a stasis in this loop. This loop will be dilated, and it can lead at the end to cholestasis. Standard management for these cases was surgery. I will show here an example. 1 second. This case had afferent loop syndrome. The patient was referred to us from outside. They put for him a percutaneous biliary drainage. And we advised the patient that we can do gastroenterostomy for him to release this tension. So we can see here from, it is not gastroenterostomy. Actually, I punctured here from the small bowel. So it is enteroenterostomy. Again, the video. So we identify, we give through the percutaneous biliary drainage. We fill the afferent loop with water and contrast medium. As we can see here, how huge is the afferent loop. We are here from another small bowel loop. We puncture inside the afferent loop with the needle. And then we inject some contrast metal. We can see here the turbulence of the contrast metal inside the small bowel. And then after we are sure that we are in the right loop, we puncture with axius again. We withdraw it back before we deploy the proximal part. Yes, I think it's the next video. Here we can see here the axius stent is completely deployed, and we don't have any contrast metal or medium in the afferent loop. I dilated it with the balloon, and the contrast medium came quickly through the small bowel to the stomach, and we can see it here endoscopically. The axis, and we can see here very nicely that was the percutaneous drainage. We can see it here through the axius in the small bowel. And we're able to remove later on the percutaneous drainage because the patient didn't need it anymore. Conclusion, EUS guided gastroenterostomy is associated with equivalent efficacy and safety as compared to surgical gastroenterostomy. It is ideal for malignant gastric outlet obstruction till now, because there is not a lot of literature in benign cases. I myself didn't do it with benign cases till now, although there are some papers about it, but maybe I didn't find the right cases. Of course, further technical modification and developments are warranted to assure more safety for this technique. And which patient can profit from this technique? I would say patients with expected life or with long life expectancy longer than 2 months, then I would prefer to put gastroenterostomy instead of duodenal stent. That was all. Thank you very much.
Thank you, Hazem, Hakim. Thank you, Dr. Mohamed, for this informative lecture. I have one question for you. In which patient you prefer enteral stent better than gastroenterostomy casual intrastent dural stent or which or like this?
Actually, if the life expectancy is very low of the patient, which is also, we see this patient not that often, but then if the life expectancy is less than 2 months, I would put a stent.
As regard if there is multiple collaterals or ascites, you prefer also
ascites is not, of course, is not an absolute contraindication for this technique. I will consider it like PIC. We can aspirate the ascites immediately before the procedure. From my experience, I did it with many cases. They went very fine. The most important thing, you shouldn't have ascites between your loop and the stomach. The small bowel is very tricky. It is very mobile. You see it, and in few seconds it can move away. That's why you have to choose a stable position. Usually at the ligament of trips or trites, it is a very good position. It is most stable than the other parts. It is near for the stomach. You have to give Buscopan. It is a mandatory. Otherwise, really the motility is a big issue in this procedure. But other than that, if you're in a good position, no motility, it should be a very safe procedure after adequate preparation and good experience, of course.
Thanks, Dr. Mohamed.
Thank you very much.
I have 3 short questions, Dr. Hazem. Can I ask? Or you have many? Dr. Mohamed, thank you for this very nice lecture. I think we should start this technique in Egypt. My first question is, I think the most applicable one is to push a large amount of fluid through the cannula or catheter or nasogastric tube into the jejunum, because in many instances you don't have the single balloon or double balloon tube. My question is, what is the different ratios of this mixture? How many cc methylene blue, how many cc's dye, and how many cc's saline or water, and the total volume which is injected. What is the total volume injection? 1 liter, half a liter?
Actually, there is no composition. The blue, I make it. I tell the nurse to just make it blue. I put the blue color just when I put the axis. I want to see it. I want to see a blue color, and when I puncture the needle, I want to see a blue color. So it doesn't make a big difference how much. It's a personal preference, and the contrast medium. We mix it also. We should see it on the fluoroscopy. Rather than that, there is no real measurement for this. Regarding the volume, this is a very good question. At the beginning, we used to do it with a pump, and it was an advice from Ben Miller, the inventor of the stent, of the Axios stent. But there is a big problem if you give a big amount of fluid, like 1 liter or 2 liters. It will move very quickly away, and then you have many loops, not just 1 or 2 loops of small bowel you are looking for. It really, you'll have many loops all over the examination, and you will not know exactly which one that you want to target at the ligament of Treitz. That's why now we switched. Instead of the pump, we just give with the 20 milliliter syringe the fluid. After giving the Buscopan, we start to give the fluid until you are convenient and confident that you can puncture at this area. Usually you achieve this after like 7 to 10 injections. So we are talking about 200, 300 milliliters. It depends. Sometimes you will need more if the examination is taking more. But as longer as you're giving fluid and waiting, as more loops will be filled with the fluid. You also have to take care with the CT, because some cases they receive CT 1 day before it or just short before the examination, and the colon can be filled with fluid and contrast medium. It can be mixed up. So you have to just take this in consideration.
You took, as I understood, after injecting water by the cannula, you remove the scope, the forward view scope, and the cannula itself, the nasogastric or whatever the cannula. You leave the cannula.
The nasobiliary.
You remove the.
Exactly. You remove.
Yes, you remove.
And then you fix
the scope, but leaving the cannula.
Exactly. And during the examination, you will give the water. And for me, the most assurance signs that this is the right loop, when my assistant or the nurse start to inject fluid or continuously give fluid, I see the turbulence of the water. Then
the turbulence, yes, very nice, very nice. And if you remove the cannula out away, and by the time you go to the echo endoscope, the fluid will push away in the small bowel. So you should keep a very long cannula or nasogastric tube and start injecting while both are inside the patient. The echo endoscope inside the stomach, and the cannula is inside the small bowel.
And there's a very important thing I want to say. At the beginning, when someone is starting to doing this technique, of course, for assurance, some people will come with a needle, puncture with a needle, and then they will put a wire, and they want to come over this wire with the axial stent.
Yes.
That they are sure that they will puncture in the right position. This is one of the biggest mistakes that can be done in this technique, because it will very, very common will happen. And if we read the Khashab studies at the beginning, the only complications that they had, and my 2 complications at the beginning was because I used the wire. The wire will push away the small bowel. The jug wire has already some tension. And if you put the wire under the fluoroscopy, you believe you are in the small bowel. Under endosonography, it is unclear. Sometimes it is ascites, sometimes another loop is moving around and your loop is moved away, and then you will deploy the stent in the peritoneum. The best way to use the axius under endoscopic vision, just do the direct puncture without putting any wire.
Yes. Then you remove the wire. Just 2 short questions, please, because the subject is very interesting. The exact site at the stomach, where you locate the echo endoscope and prefer the site of puncture in the stomach, at the angula or pre-pyloric, or just guided by the loop you are injecting water inside? Could it be done in the body of the stomach or in the fundus of the stomach, or there is a preferred anatomical location, or it is, as I said, according to the field loop you want, then you would do at that site?
Usually it will depend mainly on the endosonography, but most of the cases you will find the best loop where the ligament of Treitz is at the distal body of the stomach, at the direction of the great curvature. That would be in the most of cases will be the optimum location. But again, you are depending completely on the endosonographic examination.
But the most common site, as I saw in the video, is 9 o'clock between the body and the antrum of the stomach.
Exactly. You can say distal body, proximal antrum is the best.
Then the last question: most of endosonographers prefer axius stent. Did you try gastroenterostomy with other lamps like Spexius or Nagy stent?
Unfortunately, not yet,
because it's very expensive.
Yes, I know, and this is, I think, it would be a big problem in Egypt, because here I don't think twice before opening an axius, and I think in Egypt it would be a big issue. I can tell you later, because we will start to order the other stents in the next couple of months. If I have an experience with it, of course I will tell you. But right now I only use the axius stent.
Okay, very interesting, very nice lecture, very useful, very valuable. And I'd like to ask you a personal question, that we should keep in touch in all things you are doing and all things we are doing.
Definitely.
And the cooperation, I think the cooperation, the most important item in our work is cooperation and change of knowledge.
I would be glad if we can meet every now and then, making like a small meeting or sitting together online even. It would be great, really, to exchange. I also have many questions for you, for Dr. Khalid, for Dr. Hazem, for Dr. Ghanim, for everyone. So I think we should meet maybe like a small meetings together.
Then I think we are just now in time. We come to the last. We finished the 4 lectures. Thanks for all of you. Lectures are very, very interesting, very valuable. Really, I enjoyed it, and I hope that all our colleagues and audience are enjoyed it. and there are just left a few questions in the screen, in my screen, and I will ask Dr. Hazem Hakim and Dr. Ramil Hindawi to guide us 12 questions. I think we answered most of them. Dr. Hazem Hakim, would you like to take the lead to
I think that the questions for Said Ghunaim for lecture.
And our speakers will answer it. Do you have the screen?
Yes.
Do you have the questions at the bottom of the screen?
Yes, Dr. Said. The first question is the
first question. I think it was answered before. It was answered before. Okay. The second one.
Yes. The second, what about the cell block? The size of cell block, I think.
Cell block, Dr. Said Ghunaim.
About macroscopic or what?
Do you prefer to prepare cell block in addition to the slides in FNE or FNB?
FNB, yes.
Yes, there should be a formalin block.
Formalin, yes.
Maybe cell block will be prepared for the remaining material, Dr. Hassan. From the remaining material for after preparing the slides, so the remaining material will be sent for cell block. I think that.
Yes, I think cell block is very important. In my experience, cytopathologists are very happy with the slides more than the formalin block. This is my personal, and this is a personal notice or personal experience. But formalin block is very important because if the cytopathologist need to do immunohistochemistry, there should be a formalin block because the slides were stained with hematoxylin and eosine, so you can't do it immunohistochemistry with these slides further. So you should have a formalin block to prepare for how to do immunohistochemistry if needed in case of lymphoma or GIST or something like that, or neuroendocrine tumor.
I think Dr. Hussein, cytopathology is sufficient in a straightforward case. But if we need histology like in GIST, as you said, or lymphoma or autoimmune pancreatitis, we need in this case cell block.
Yes, to do immunohistochemistry.
Yes.
For Dr. Hazem.
Another question for Dr. Mohamed, when to refer one to surgery, and what about multi-gate drainage?
Very nice question. When to refer one for surgery, it would be, I didn't till now, to be honest. Only cases that you can't reach endoscopically, but again, I would start with percutaneous. If the radiologist said he can't drain it, there is no access for percutaneous endoscopic necrosectomy, then maybe it, but I would say that would be very, very rare case. But what also a very nice question is about multi-gate drainage. To make more access, more than one access, like two from the stomach, one from the stomach, one from the duodenum, because, and it is also described in the literature that the non-contagious fluid collections. In most of the cases, even if in the CT, you don't see a connection between 2 or 3 collections. Usually they are connected. And we see it often when we start to do the necrosectomy, especially if we have external drainage in the other collection, after like 2, 3, 4 sessions, and you are giving dye or blue dye from the external drainage, they are connected at the end, usually can reach from one collection to another. But if they are really completely separated collections, yes, you can do go for multi-gate drainage. The drainage should be in optimal position, and from my point of view, the best opening for necrosectomy should be proximal and straight as much as possible. If you will do it distal, it is fine. For drainage and gravity, it is better, but it will be very difficult for you to come in distal opening and do the necrosectomy. And there is another question, I think. It is
there is in the area of lamps. if there is any role for plastic stent and all.
Lamps they are expensive, and I think they are not affordable everywhere. So yes, pigtails still are a big player in the field, and also lamps with axios. You can't leave axios more than 4 weeks. If we have a patient with a huge necrosis who will stay more than 4 weeks in the hospital, one day we'll remove the axios and we'll put pigtails. So of course the pigtails are still big players.
I think that all questions for you, Dr. Mohamed.
Okay, 15 millimeter may cause separation of cyst from the wall. I don't understand if he means if you will dilate till 15 millimeter, it is a big risk. No, actually, the wall of the cyst, the anterior wall of the cyst is the stomach, the wall of the stomach. It is not a real wall. The cyst doesn't have a real wall. So it is anterior border is the stomach usually. So if you dilate from it, it is not a problem. Even you can reach 20 or more than 20. I never seen separation of the cyst or wall. I think it is not true. If you witness something like this, maybe the position of the puncture was not accurate. Maybe it went in peritoneal direction, not in the retroperitoneum. How to deal with disconnected duct syndrome? A great question. It is very common. More than 30 or 40% of patients with duodenal pancreatic necrosis will suffer from disconnected duct syndrome. The best treatment from my point of view, if it is a complete disruption, leave the stents, leave the drainage. If you put pigtails at the end, you did your necrosectomy, leave the stents, leave them 2 years. It is not a problem. There is no reported cases from problems from leaving the stents through the transgastric drainage. Why is that? The duct is disconnected. That means the pancreatic secretion is coming in the cavity. Now we have a drainage in the stomach. So actually we have done a pancreatostomy or a pancreatico-gastrostomy, I would say. It is already a drainage operation. And with the hope that like after 1 or 2 years, even if you remove the stent, the fistula will stay, which will ensure complete drainage of the pancreas in the gastrointestinal tract and not in a closed cavity. But if you already remove the stents and you are sure about the disconnected duct syndrome and it is not completely disconnected, it is partial disruption, like 50%. In some cases, you can bridge it with a wire and put a stent. But my preferred method is just put a drainage in the stomach and leave them as long as you can.
Thanks, Dr. Mohamed.
Thank you very much.
Thank you.
And Dr. Mohamed, and that question is very important. If you, in the first place, put a metal stent and it is a disconnected duct syndrome, then the metal stent, you can keep it for more than 4 or 6 weeks.
Yes.
Then you remove the metal stent and to use the plastic stent. And how to do this through you should remove it first and then you should apply plastic stents, but it will be very difficult because the cavity is collapsed. Very difficult to place a plastic stent in a collapsed cavity. So you would prefer to leave it for a short while, and if it recollected again, especially in disconnected duct syndrome, then you introduce then plastic stents, or what your policy in that item?
If through the axios I see a complete collapse of just a granulation tissue, then it is completely collapsed, then I will remove it. But in most of the cases, when we remove the axios, you still have a small cavity, very small cavity, something like 2 centimeters, then I will put 4 centimeters pigtails. If it collapsed completely, this 4 centimeters pigtails will be thrown in the stomach and will come with the bowel movement, will be extracted. So it depends on the picture of the cavity after the 4 weeks. If it is from the first place with just a pseudocyst or an abscess, I will just remove the stent and wait.
Yes.
Mohamed.
Okay.
Mohamed.
Dr. Hazem.
سيد وين معك دكتور حسين؟
دكتور سيد تفضل.
دكتور سيد.
I would ask about the duration of leaving plastic stent in cyst drainage when you use a plastic stent. Do you prefer to remove it or to leave it? As you know, pancreatic duct dissection syndrome is challenging to diagnose it even by MRCP, even by EUS. As you said, there is no complication to leave the stent. Why we didn't leave the stent for life or for more than 2 years, as you said?
Still a very good question. How long do you leave the stents? The literature will never answer this question. What you will find in the literature and with the experience that as long as you leave is better. There is a study, zum Beispiel, for example, they compared 48 months leaving the stents, and the recurrence rate was much lower in comparison to patients who removed the stents earlier than 3, 6, or 9 months. So I would never recommend to remove them before 6 months. And I usually leave them, as I said, 1 to 2 years after the drainage. The recurrence rate is not low. You have a recurrence rate between, I think, 15 till 33% after removing the pigtails, which is a big number. And this patient will come again for a new puncture and a new drainage. So if they don't make complications, why not to leave them?
And I think now all the questions were answered, but I have a very last question, and maybe of importance. Yes.
I think also Dr. Ansari has a question, but please ask your question first, please.
Me and Dr. Khalid Ragab and Dr. Said Ghunim and me issued a multi-center study about leaving in pancreatic pseudocyst, not in walled off pancreatic necrosis, in pancreatic pseudocyst, leaving or putting 1 double pigtail 10 French stent versus 2 double pigtail 10 French stents. And we can dilate a little bit for a wider, dilate for about 10 to 20 millimeter balloon dilatation and putting single stent. And we find, I think we had Dr. Sayed about 40 or 50 cases, I think.
35
and we
cases,
didn't
35 cases.
We didn't find any difference between putting single double pigtail stent 10 French or multiple all two double pigtail plastic stents. But in case of single, we do a little bit more dilatation at least 12 millimeter, 10 to 12 millimeter. What is your opinion about that?
I always afraid with single stent. If you put a single stent is your only drainage. If you put 2 stents, the space between 2 stents will work as this, they call it siphon mechanism. So even the stents get occluded, and they will get a pigtail will be occluded in the stomach, I think, in a couple of days or weeks. If you have 2 stents and both are circular, so there is a small space between them. If the pressure increased in the cavity for any reason, like recurrence, like still fistula in the pancreas or disrupted duct syndrome, the fluid will escape between these 2 stents, and this mechanism is described in the literature as siphon mechanism. I understand, of course, if it is just a pseudocyst with no pancreatic disruption, of course, 1 stent will be enough because you just need to evacuate. If there is debris or thick fluid like abscess or necrosis, I think 1 stent would not be enough.
Okay.
Necrosis,
yes.
We exclude cases with necrosis more than 30%, and most of our cases have necrosis less than 10%, 5 to 10%. And we have result of, I think, 1 case of recurrence, and whole case no recurrence.
This is great. Regarding estimation of the amount of the necrosis, I couldn't ever estimate the necrosis. Sometimes you believe the necrosis is really low 10%, and the whole cavity is full of necrosis, and sometimes you believe it is full of necrosis and there is no necrosis inside. I think there is no single modality that you can trust with this measurement, except that you come inside and you start the necrosis till you finish it. Then you will know how much necrosis was inside. But this is very interesting, this study. I would love to read it, because 1 stent, I was always cautious with 1 stent. But yeah, it's great. And I think Dr. Ansari asked the question, Dr. Mohamed, about the EUS features that differentiate. Dr. Ansari is asking about the endosonographic features that differentiate wall of pancreatic necrosis and pancreas pseudocyst. As I said, you can't trust any modality. You can expect, you can suspect, but like seeing a tissue, mobile tissue inside the cyst, but sometimes it is not really a tissue or a necrotic tissue. So there's nothing you can trust. You hope. Actually, I know with the first puncture from the color of the fluid, if it have some debris and some necrotic segment, that it is most probably has a necrotic element.
Then we are.
Thank you so much.
Any questions? Now we are in time.
Thanks a lot, Dr. Mohamed.
Thank you, Dr. Ansari. ربنا يخليك. Thank you, Dr.
Thanks a lot.
We are now just in time. Very nice. Time is very well adjusted. I just finally would like to announce two important EUS occasions. The first one of tomorrow, the last day of our EUS course, 4 days in 4 weeks. Tomorrow, Saturday, in the same time, 7:30 p.m. Cairo local time will be the last day, and it will be very interesting day. Dr. Anna from Poland will talk us about celiac plexus neurolysis. I will talk about EUS-guided radiofrequency ablation, a very promising technique, especially in neuroendocrine tumor, especially in selenoma. And there will be 3 video cases, very interesting. One of how to deal with gastric varices, EUS guided, coiling and desocrel injection by Katarzyna Pawlak, Dr. Katarzyna Pawlak, a very active person from Poland. And the second one by Dr. Rasha from Asyut, of different cases of pancreatitis, usual pancreatitis, groove pancreatitis, autoimmune pancreatitis, and so on. And the last video is the forgotten left suprarenal or suprarenal masses, some video cases. So it will be a very interesting day tomorrow. I hope that you will continue your journey with us tomorrow. And the second event is the second EUS Egypt. It will be a web event. It will be a virtual event, and it will be next Friday after 7 days on 30 of October. Next Friday will be with us Professor Marc Giovannini, of course, from Marseille, France, and Dr. Hakim Sentorok from Istanbul, Turkey, and Dr. Mohamed Osman from Houston, Texas, Baylor University, and Dr. Kalpesh Patel, a colleague of Dr. Mohamed Osman in Baylor, in Houston. Very different variable subjects will be very interesting, and it will be on next Friday, 30 October, starting 3 p.m. The announcement and the active link of registration will be soon tomorrow after the end of the 4 days. At the end, I'd like first to thank my dear colleagues who are interested in endoscopic ultrasound. 100 participants, 100 something, from 100 to 200 all over the course. Very interested, staying from the first minute to the last minute. Thank you very much for your interest in endoscopic ultrasound. And of course, I'd like to thank my dear colleagues who are volunteered to share us despite their busy agenda and limited time. Thanks very much, Dr. Mohamed Abdel Hafez. We are honored and pleased to be with us. Thanks very much, Dr. Khalid Ragab, Dr. Said Ghunim, Dr. Hazem Hakim, Dr. Rami Al-Hindawi, and all of our colleagues participated in the previous 2 days. And I'd like to thank, of course, Utopia Pharmaceutical Company, Dr. Siola, Samir Raghib, and Mr. Ahmed Magdi, and Dr. Mohamed Jamil. They did a lot of effort to regulate these EUS events. And thank you very much again and again. and I think are now reached the end of this day. Very nice day, very valuable. Man is always learning, and changing of knowledge should be one of utmost interest in this world. Anyone wants to say something before closing the session?
Thank you all.
Thank you, Dr. Hussein, very much. Thank you.
Okay, thank you very much, and see you again and again in our journey in endoscopic ultrasound.
Thank you, Dr.
شكرا دكتورة سيولا، شكرا باشمهندس.
العفو على ايه يا دكتور، انا تحت امر.
شكرا يا دكتور.
ميرسي يا دكتور.